Okay, so we're gonna say good afternoon and thank you for the good work on the last exercise, and we're now moving into research paradigms. So what we did earlier was we looked at how we determine research priorities, because we want to make sure that our research topics are aligned with priorities. But we actually saw in this exercise that it's not so easy to decide on priorities, because we have different starting points in terms of reaching a consensus on what those priorities are. And that kind of exercise magnified at a level of where national priorities are set, you can imagine requires a lot of deliberation and a lot of time, which is why, unfortunately, not many countries go through that exercise in a very systematic way. So I think this is very, very important. When you look at lists of these are the research priorities in our health plan, look at them critically. Ask, how did they reach those decisions? Okay, good. So now we're moving into what is referred to as research paradigms and the role of theory. So you have thought about problems and how to define problems. I gave you some tips already. We'll be working a lot more on that as we move into the case studies. But now we're going to actually think a little bit more about how our disciplinary background and our theoretical understandings of the topic influence the way we ask questions. And we're going to talk a little bit about theory more generally. So what exactly is meant by a research paradigm? Yeah, you probably have heard the expression in your studies. People will have talked about paradigms, and it's never, again, it's not a very easy term to think about, because a paradigm, sometimes people think about it as a model, sometimes they think about it as a theory, sometimes they think about it as a philosophical position, how you think about the world, how you view reality. So I hope to shed some clarity on that. Any kind of research is influenced by the researcher's understanding of reality and how to assess it, yeah? So even if you say, I'm a quantitative researcher, I only do numbers, you still have that assumption that you can measure the reality through numbers, which is already, even though you might not say there's a theory there, it is a theoretical position, because you're saying that this reality of whatever health condition you're looking at or whatever phenomenon you're looking at can be categorized in a way that allows quantification, yeah? So what I'm urging you to do is that to reflect much more carefully on the type of research you do, and to be more explicit about how you understand the reality that you're trying to assess. What can be known about it, and what decisions you make about what aspects you can and can't measure. Because you're, let's put it this way, whatever research you do is always going to reveal a partial truth, yeah? Never going to be the full comprehensive picture, because it depends on your starting point and what you can measure. So be clear about what you can measure and what you are able to document. So a very interesting definition from Thomas Kuhn, who was somebody who wrote a book, a philosopher who wrote a book called The Structure of Scientific Revolutions, and who talked about the great paradigm shifts in terms of our scientific thinking, from going from an idea of the world being flat to the world, you know, the earth being round, and is still very influential in terms of the way we shift our ideas in scientific understanding of problems. He defined a research paradigm as the set of common beliefs or agreements that's shared between scientists about how problems should be understood and addressed. And the reason why his work was so influential is he introduced this idea that paradigms move. They're not fixed, they're not static, yeah? So even within the course of your lifetime as a researcher, your own paradigms for approaching your study topic might change, yeah? A paradigm is the fundamental basis of your research project, okay? It's really the bottom, the underpinnings of the project. It informs your questions, your study design, and your methods. And normally we think about the research paradigm as consisting of three main components. The first is epistemology. So these are philosophical concepts, so bear with me, but essentially, epistemology is the nature of knowledge and the process by which knowledge is acquired and validated. So how do we know what we know? Yeah? How is it that, this is why, before in our research priority setting exercise, I was asking you to reflect on why is it that that you believe you know that this is a priority? How do you know what you know? Yeah? What constitutes a powerful form of evidence or knowledge for you, and where is that knowledge coming from? But before that actually is ontology. So I should have started up front. So ontology is the nature of your beliefs about reality. So what is reality? Yeah? What constitutes reality? The epistemology is how do I grasp that reality? How do I know what I know about this reality? And then the methodology is your theoretically informed approach to the production of data. So how do you go about acquiring that knowledge? So it sounds complicated, but essentially, if we think about it from a very practical example, let's say that you were looking at stress I think you mentioned ASHA workers a number of times, okay? Levels of stress in ASHA workers who are burdened with multiple programs that they have to deliver, okay? So your ontological question is that you're first trying to understand the concept or the construct of stress. What does stress mean for this particular group, yeah? The ontology is around what is the reality of this construct? What does stress mean? Yeah, what is the construct? How do I define it? How do we know what we know is what are the assumptions that inform how I'm going to assess stress? Okay, so if we ask the 5 tables to think about how you would go about capturing the reality of stress among ASHA workers, I can bet you that you would come up with quite different ways of doing that. Okay? Now you probably are more used to starting here, which is that you think about methods. You think, okay, I'm going to go and do a survey, or I'm going to go do some qualitative interviews, or I'm going to observe their situations. I'm going to accompany them as they go, on their daily work practices. And I'm going to assess to what extent I notice that they're coming into stressful situations. But actually, you need to go a step back, which is to be clear that through methods are already quite a step far along. You first need to decide what is the construct, what is the reality you want to look at, and what kinds of knowledge do you think are worth documenting in order to be able to say something about stress in this group. And then you go to the methods, okay? So a research paradigm actually consists of these 3 components. So we're going to talk about 4 key paradigms in health policy and systems research. And this is based on years of teaching both qualitative research, where we talk a lot about research paradigms, but also teaching both at my former institution as well as ITM in Antwerp, and looking more into the paradigms that specifically shape health policy and systems research. So the first paradigm is the one that you may be most familiar with, which is a positivist paradigm. And again, because of lack of time, I have to caricaturize these paradigms a bit. Normally we would take a week of a course on positivism, or a week of a course, but we don't have a week, we have 10 minutes. So positivism is essentially when you say everything is measurable, everything exists independently of the observer. It's stable and it's cohesive. I pick up this pen, the reality of this pen is something I can measure. I can document the size, the texture, the material. All of this can be captured through objective measurements, okay? Because everybody would agree, this is not a pen, but this is a pointer. Yeah, it's a laser pointer, okay? Your positivist doesn't spend a long time deciding, is this a pointer? Is this a pen? Is this a plastic object? What is it? They're not going to think about the ontology of this object, right? They're not thinking about the meaning. They're thinking about this as an object which can be captured through some kind of methods to say, okay, let's assess, how many of these pointers do we have? I mean, sorry, this is a silly example, but you get my drift here. For the positivist, the reality of what they're trying to measure is driven by natural or fixed laws and can be described objectively through empirical research. And that requires that you exclude, you control for anything that you think might influence or selectively bias your perception of what this is. Okay? So again, carrying with this example, if you said, I want to do a survey of how many classrooms in the Department of Health Sciences have functioning, whatever they're called, laser pointers, okay? You're making an assumption that everybody knows what a laser pointer is, and you're making an assumption that all of them have more or less the same kind of functionality. In other words, if X isn't if X isn't working, the battery isn't working, then etc. So you have certain assumptions across the board in terms of the reality you're trying to measure, and that allows you to proceed with a specific set of methods. You cannot get into anything that would influence how this pointer is being used, where it's being used, who's using it, who gets to use it more than others, is considered a contextual influence on whether these things are functional or not, and you would try to control for it. Okay, I know this is not the best example, but I will figure some other ones out. So the instruments are standardized, and you're emphasizing generalizability and reliability. So in other words, if 5 of you selected did the same piece of research, you should come up with exactly the same results. Okay? There's no room for subjective interpretation. So these are some questions in HPSR which would rely on a positivist approach, or could. Is the policy or intervention cost effective? Why does that sound like a positivist approach to you? Or why could it be addressed through a positivist strategy? What do you do in a cost effectiveness study? Yeah?
Right, so you can measure the input and output, like whether the amount of input is giving you the correct amount of output. Mm-hmm. So it's something that's measurable objectively. Mm-hmm. So maybe that's why it's positivist.
Okay, so a cost effectiveness study assumes that for my intervention, I should be able to capture the reality of all the inputs, as you said, that are required for that intervention. So the training, the materials, the staff costs, the infrastructural costs, I should be able to capture that objectively. And I should also be able to capture the information on costs, how much they cost. And there should be a measure of effectiveness as well, which is introducing a training intervention is a complex intervention, which is why it's more difficult to do it through a positivist approach. But if we're looking at something which is a bit more straightforward, where the costs are relatively easy to measure, and the effectiveness is also relatively easy to measure, then you would say, okay, I can do this through this approach. What is the quality of care in X ward? Okay? Now, per se, the question isn't necessarily a question that should be answered through a positivist approach, but you can, okay? How do you make this a positivist question? You set the boundaries of exactly what you mean by quality, okay? Completely fixed, so that, as I said, 4 or 5 different people, researchers among you would use the same standardized tool to measure quality. Okay? But just by looking at the question doesn't tell you whether this is positivist or not. It's the approach. Yeah? So as soon as you predefine, the researcher predefines what they're measuring and standardizes the approach and says that the approach that's going to be taken is a reliable approach, it's something that's been tested before, etc., then you're moving into a positivist approach because you're assuming that the measurement that you're using is not biased by any subjective interpretation of the person who's administering the instrument. Okay, that's very different from a relativist or a social constructivist approach. Sorry, there's something missing up there. Social constructivism should be. So here, the idea is that your social reality, or your reality in general, is cohesive and ordered, but it is apprehended subjectively. So in terms of the ontology, what is the reality? Let's go back to our example of the stress in the A&M, not A&M, the ASHA workers, okay? A positivist comes up with a scale and they say, okay, I've got 4 things that I'm going to look at stress. I'm going to look at fatigue, lack of concentration, some kind of mental health effects, etc. But each of those items is going to be categorized in a way that can be measured the same across the board. So I apply this tool and I'm basically predefining how I measure stress. Okay? In this case, we're not using a standardized predefined tool. We're assuming that the reality of stress cannot be known through a tool. We can only know it if we ask people themselves about what stress means to them. So the reality is a subjective reality. It exists, but it exists differently for different ashas. Okay? And it focuses this social constructivist perspective, which underpins most of the social sciences in terms of the research, but there's also positivist approaches used in the social sciences, but is that it focuses on how individuals themselves make sense of the world through their perceptions, their feelings, their emotions, the meanings that are attached to a particular construct, which means that there could be multiple realities because you conduct interviews to understand what stress means for ASHA workers in different states, or for older and younger, or for whatever, and you're going to get lots of different ideas about stress. You're going to get a very interesting, probably, understanding that stress means different things to different people. It has different consequences for different people, right? So this approach is really centered on meaning and what do things mean in context. Because you really want to understand how the context of the workplace, the work burden, the family life, how all those contextual factors might influence how that person defines and experiences the stress. Okay? Your methods in this case are not standardized. They are open-ended, they're flexible, and they're centered on this experience of reality, which is shifts according to who you speak to. So examples here, how do patients experience a new quality of care initiative? So in the positivist approach, we said, what is the quality of care here? And we said we could approach that in a very standardized way, or we could sort of ask people, what does quality of care mean to you? And do you think this health center offers you good quality of care? And again, you're going to get a lot of different responses, because for some people, quality of care means the provider was very friendly, or the provider was wearing a white lab coat, which was very clean. Yeah? You get all kinds of things. And here's another example. What's the impact of gendered power dynamics on nurse-doctor relations in this clinic? Okay? Your construct here is gendered power dynamics. But what this means in that context, we don't know yet. Okay? So we're going to try to approach it through a constructivist. Okay? So relativist and constructivist means the same thing. You can stick with social constructionism if you like. But in principle, relativist just refers to the fact that the reality is relative to your person. It is not so relative as opposed to fixed. Okay, any questions on that? I think this will you be familiar probably from your training already. Okay, the third paradigm we're looking at in health policy and systems research is something called realism. And this is a paradigm that is kind of in between positivist and constructivist. So here they're saying that the ontology, the reality I'm capturing, is independent of the observer, but both the natural and the social worlds are real, yeah? And knowing reality through science is always relative to researchers' positions and their perceptions. But this is an approach that is often taken for explanatory studies. So where you're trying to build a theory about why something is happening in the health system. So very often you will have heard of realist reviews or realist evaluation or realist approaches. And basically you're often looking at issues of causality and mechanisms. So how is this intervention working in this particular setting? For whom is it working? Why does it work in this setting but not in this setting? Yeah? And in what circumstance does my intervention work? So it's very helpful in terms of making sense of interventions and programs that are complex and that have outcomes that are context dependent. So we'll be taking an entire session of study design looking at approaches, realist approaches in evaluation, because evaluation science, where you're evaluating an intervention, often or could work with a realist approach. So your types of questions are how or why does this intervention work or not work under specific contextual factors? Yeah, because that's usually very interesting, is that you implement something across the country, but you notice they're doing much better in Maharashtra than in Madhya Pradesh. Why is that? What are the contextual issues? What are the mechanisms that make the intervention work in this setting but not in this setting? Yeah? So how and why do pay-for-performance programs implemented in low and middle income countries result in intended or unintended outcomes? Okay? So it's very often focused on an intervention, and I'm saying intervention in the broadest understanding of the term. Yeah, because an intervention can be as simple as introducing a new waiting room. Yeah, you might not think of it as an intervention, but it is an intervention because by introducing a new waiting room, you create all kinds of new dynamics. And it's not just about moving people into the waiting space, it's whether they want to sit in that waiting space. So I'll just give you an interesting example. In South Africa, in that project that we were looking at in infection prevention control, one of the interventions suggested was to create outdoor waiting spaces because it would be much better in terms of ventilation. It's a hot country, you could have a nice shaded area. And actually later when they did some of the qualitative work, they found that people hated the idea of outdoor waiting spaces. Why? Because they felt that everybody who had to sit outdoors was made to feel that they were somehow lower in terms of social status than the ones that got to sit indoors. So we would have never anticipated that, right? That actually the place where you wait in a health center may be associated with, your perception of your worth, your social worth in the system and how you're treated by the system. So if you're made to wait outside, there must be something, they don't want me inside the facility because they think I'm whatever, low caste, low class, already sick, etc. So that's just an example of where a simple thing like that, we needed to do that kind of research to see why is this not something that's acceptable. Okay, and your last paradigm that we're going to talk about is a so-called activist paradigm. Yeah, so this is the starting point for an activist paradigm. Is that reality exists, yes, there's a measurable reality, but it has been shaped or skewed. Skewed means biased, yeah? By cultural, political, ethnic, gender, religious factors which create inherently unequal systems. So here there's a focus a lot on power hierarchies. Power is central to this type of research because you're trying to uncover injustices, unequal relations, inequities. And there's also a focus on sources of authoritative knowledge. So authoritative knowledge means we're trying to look at why it is that some types of science or some interventions or some groups are prioritized over others. Why does it become commonplace? Nobody questions it anymore. It's just the way it functions. And there's some very interesting work in India, especially in maternal health, I think, looking at how certain hierarchies, gender hierarchies, and caste hierarchies become implicit to the internal bureaucratic systems. And it's something nobody blinks an eyelid here because it's so much part of daily life. But when you look at it from the outside and you say, well, what's going on here? Why did it take so much longer here? Why is there so many delays here? And you understand it as a function of inequalities that are often implicit, not explicit. Then you can adopt a more critical stance on how you would change those things. So this kind of research is explicitly used to uncover power imbalances, inequalities, and to inform social change. And the approaches designed to collect data are often trying very hard to not only to impact participants, but to change systems, but also to incorporate participants in the research. So Solomon and I will do a session on participatory action approaches, which to some extent take on a more activist approach. Not all of participatory research is necessarily activist, but a lot of it is, because the idea is that you cannot do things to communities without them, right? So examples of questions are, what are the social processes, the structural factors, including power relations, that explain differences in people's access to or experience of the intervention? Okay? And the assumption is when you see that there are differences in terms of uptake of an intervention, the activist is always going to be looking at the power issues behind that. Okay, so I'm going to take you through a couple of papers where I want you, it's going to be a bit strenuous because you're going to have to read online, which is never very fun, but I want you to try to think about what paradigm you think informs the research and where do you see this. Okay, so remember we have positivist, we've got social constructivist, we have realist, and we've got activist. Okay? All right. Okay, this paper is called The Social Context of Tuberculosis Treatment in Urban Risk Groups in the United Kingdom, a qualitative interview study. So I want you to briefly look through the text. This is just the abstract. And then I'm going to pick on a table, a particular table, and I'm going to ask you what you think, what research paradigm underlines this study and why. Where do you see that? I'll give you just a minute or so to look through, to scan actually. Okay, so this table, what do you think it is? First of all, what is the reality they're trying to capture?
So the study was aimed to capture the experiences of tuberculosis treatment in...
Good, okay. Experiences of tuberculosis treatment.
Yes.
Everybody agreed? That's the thing, that the reality they're trying to capture, okay? What do you think the paradigm is here?
I think so it's positivism.
Positivism.
Yeah, the first.
Why?
My colleague is thinking it's relativism, but I thought we can actually measure, like the study is aimed to describe the social context of adherence to treatment, so they can measure who are following adherence to
but
that.
read through
and
the
not.
methods. Read through the methods, okay, before you say it's positivist. I'm not arguing with you, but I'm just saying make sure you look through carefully. Yeah?
Yeah, I haven't read everything, but yes.
Okay. Experiences of TB treatment. Anybody else? Anybody disagree that this is a positivist study?
Um,
Yeah?
I think because it's focusing on individual experiences of the so maybe it has a relativist approach because it's focusing on individual experiences of patients with receiving the treatment.
Okay. Can you, when you look through the sections of the abstract, are there other things that jump out at you that make you think this is relativist or this is positivist? Go ahead, Shivani.
I think it is activist because it has, there are social it is looking at the social structures
Okay, where do you see that?
in the methods
And where else?
and in the aim of the studies also to
Okay.
describe the social context of adherence to treatment.
Okay. Okay, so far we have positivist, we have positivist, relativist, and realist. Anybody want to suggest that this is activist? I mean, a realist, sorry. Okay, what does this table think? What do you guys think? Okay, this is very, very important to be able to do, yeah, because when you read, you've got to be conscious about what is this study being informed by? How are they measuring their reality? Yeah? Okay? It's actually a combination, I would say. I would agree with you that it's a relativist, but there is some activist element somewhere, okay? So we need to find it in the abstract, yeah? Where do we see it? Where do you see it? Look at the objectives. What gives you a clue? Okay, what are the words that jump out at you?
If we look at
Yeah?
the methods, it's a qualitative cross-sectional study.
Okay.
Like that's one point where and other thing, like if you go to the conclusion, like it is like the conclusion is saying is need for integrated care across the drug, alcohol, HIV, and homeless something. So it makes like we cannot put this into any single, like it's a reality, like what is that made me to think like that.
Okay. Okay, good. So in the objectives, there is something jumping out at you. Experience, exactly. What else? Social context, okay? Those are your buzzwords, yeah? What about in the methods? You already mentioned qualitative. What else? Semi-structured. And? The role of broader social structures in shaping health actions, yeah? In the results, do we notice anything? Yes, we do actually. We notice what you said, Shivani, the more activist bent. Why do you see some kind of an activist paradigm underpinning this? Go ahead. What do you see there? In the results.
Would it be social and institutional barriers to adherence?
Sorry, who's saying that? Yeah. Okay. Complex medical and social needs. So this still, you can say, well, doesn't necessarily tell me it's an activist study. You could measure that in a positivist way. But I think when you get to this part, participants receiving DOT reported negative and positive experience, reflecting the type of DOT provider and culture of the organization. Culture of the organization. So that's another interesting thing that they're looking at. They're saying the culture of the organization influences people's experience of treatment. Okay, another clue. In terms of your conclusions, I think what's interesting here is complexity, social needs, and I think what you already mentioned, this issue of looking at integrated care. So it's not directly starting from an activist starting point, but somehow implicitly we feel that this person is concerned with social deprivation and its impact on people's ability to stay on treatment. And actually, the conclusions are very much driving a more, a way to address this in a social way, as opposed to just saying, no, monitor them more, monitor their treatment more, watch them by video. Okay, it's a very different approach to saying integrate services for homelessness, alcohol addiction, etc. Okay, experiences, social context, broader social structures, culture of the organization, and so on, okay? So think about this when you look at a paper, always, even just looking at the abstract, you should be able to identify the paradigm. All right? Next one. Okay, so the First Nations people refers to Indigenous people in Canada. Yeah? Okay, this table, what do you think? What is the reality that's being measured? How is the reality being assessed? Sorry, I know this is not so easy, but we have to get through it. Sorry. What stands out as something that's unusual about this paper? Anything? You go ahead, just say something. Don't worry about it, even if it's off track, don't worry about it.
Analysis from the past and current
exactly.
treatment
Exactly.
scenario.
Okay, so there's something about historicity. Okay, we're not sure what it means, but when we look a little bit more into it, we realize they're talking about historical experiences of TB care, which are impacting on current behaviors. Okay, so what kind of study do you think it is? What's the paradigm? Okay, remember, is it a positivist study? Anybody think it's a positivist study? No. Okay. Is it a constructivist study or relativist study? It could be. It could be because they're using interviews, right? They're asking about experience. So that makes it a constructivist study because you're asking about what is your reality of TB treatment, okay? Is it an activist study? No, you're shaking your head. I would disagree with you. What is the premise here? What is the starting point?
Historic.
Attempts to eliminate TB among First Nations peoples in Canada must address historical legacy. Understanding the contemporary effects of treatment can be seen as part of a larger project of truth and reconciliation. So the researcher is starting with the point of view that First Nations people in Canada are very disadvantaged with regards to their experiences of TB treatment in the past. They were forcibly removed from their communities. They were moved into the urban areas, into TB sanatoria, and that was traumatizing for them. And it had a lasting effect because now there is not much trust or faith in the current day services because of this historical legacy. So that's an activist starting point because you're pointing to an injustice from the start. Okay? Or just explain to me why you would disagree.
I could think because the 2-3 things which I could make out that it could be a critical realistic, because first of all in the second line only they're trying to say that they are trying to explore the functions and building it with the historically and what is the current infectious, and then in the later paragraphs he's talking about they're trying to build a mechanism also. So I thought that it could be a critical realism.
Interesting. I never thought of that. Very interesting point. Okay, that's something I probably missed completely, but you've raised something very fascinating, which is that actually the objective is to explore the function of talking about the past, which is an activist. The activist starting point is looking at First Nations people as disadvantaged, yeah? But the realist thing you're suggesting is maybe there's something here about saying there's a larger project of truth and reconciliation. And by getting people to talk openly about what happened to them in the past can maybe shed light on the, the historical inequities. So possibly there's an element of realist study. I'm not sure I see it yet. I would have to look at the full paper, but I like that input. It's really good. Okay? All right, I'm sorry we have to get to 2 more and then I will release you, and I promise you it won't be so excruciating. Okay, historical statements is your clue. Historicity. Ongoing failure to eliminate TB from First Nations communities gives you a clue that this is an activist stance. And the larger project of truth and reconciliation is also a clue that this is an activist, but maybe potentially. Usually a realist thing is about a specific intervention. So we would have to see if this paper actually documents whether this kind of intervention of speaking about the past made a difference. I'm not sure it does actually in this paper. Okay, last one. Patients with tuberculosis experience difficulties in accessing diagnosis and treatment. Patient pathway analysis identifies mismatches between TB patient care-seeking patterns and service coverage, and so on. We developed an algorithmic approach to analyze and interpret patient-level routine data, etc., etc. We constructed 7,255 pathways for 6,258 patients, and so on. And they're reporting on their results in quantitative terms, longitudinal analysis of routine healthcare data. What kind of study? Last group? Positivist? Not, be careful, don't say positive. Positivist, yeah? If you say it's a positive study, nobody's going to know what you mean. Positive, negative? No, it's positivist, okay? Constructivist, realist. Okay, why is it positivist? Okay, I want somebody else in that group to speak. Lady in yellow. So very, very clear indication that this is a positivist study. Where do you see it? Anybody in that group? I know it's difficult to read through a text on screen. I'm sorry for that. Okay, so there's something that you should see in the methods and the results, which help you see that it's a positivist study. You're nodding, so why don't you tell me what you think it is? What is it? You're definitely nodding. I definitely saw you nodding, so you must be able to tell me what it is. Mm-hmm. Okay, so what is being measured? What is the reality that's being measured? Not sure about treatment outcomes. Is it treatment outcomes? Yes, it's pathways, right? So it's different things along the pathway. Yeah, good. And what else? What else tells you it's positivist? Look at the method.
Heterogeneity in pathway patterns.
Mm-hmm. Okay, but what's the method? What's the source for their study? Where is it? We analyzed 1 million patient records in the Taiwanese National Health Insurance database. Okay, that's your source of data. It's positivist. Positivist, why? Because it's a way of quantitatively assessing the reality of whether people have TB or not, and you're constructing on the basis of this quantitative secondary data pathways. Okay? So, patient pathway analysis, it sounds qualitative, but in this case it's quantitative. Random sample of 1 million patient records also gives you a clue. Constructed pathways, I mean, can you imagine doing qualitative work? Constructivist work with 7,255 patients? No. So the numbers also give you a clue. Yeah? Okay, good. I will spare you the anxiety of going through this one, but I'm going to tell you this is an example of a realist study, this last one. So look carefully at it. So despite progress towards NTB strategy for reducing TB incidence and deaths, South Africa remains among the top 10 high burden. Large challenge relies in how policies to improve detection, diagnosis, and treatment completion interact with drivers. So now look at the methods. Theory building case study design. Using context and implementation of complex interventions framework to identify contextual determinants of the problems in TB care. That's your clue. Yeah, it's a theory building study. They're trying to identify what are the contextual determinants that influence certain outcomes. They used mixed methods, and if you look at the results, delayed diagnosis caused by interactions between fragmented healthcare provision, limited resources, verticalized care. So they're pointing to a number of systemic mechanisms. Yeah, and in the conclusion, let's see. There's nothing there necessarily, but basically this is your clue here. Okay, and maybe this is also a bit, data was inductively analyzed and mapped onto 7 context implementation, whatever those CI contextual domains were. Okay, and TB policy needs to resolve tensions. So I appreciate this is a challenging exercise for you, right? That's completely normal. This is no class gets this like right off the bat. We also had to race through these different paradigms. But this is something that I really would encourage thinking, okay? I can share either the papers. I'm not sure the papers will make that much of a difference. But think about those 3 things. What is the reality that I'm trying to capture? What is the construct I'm trying to assess? Either quantitatively or qualitatively or whatever I'm trying to do. What is it? Is it stress? Is it TB outcomes? Is it TB treatment? Is it adherence? Is it some kind of systems issue? And then think about how will I know what I know? So what is my approach to assessing that reality? And then you look at the methods. So those are the 3 critical things that belong to a paradigm. Okay, this is yet another one, but this is another realist study where they used a realist review to examine how complex socioeconomic interventions for TB treatment and care were defined. But maybe we can give you this as homework. I'm going to give you these 5 again just to look over. Okay? Good. Okay, I think we're going to stop there because we're going to move into another small exercise where you get a chance to do this in a bit more detail. I've got to check whether we have the time to do it, but I think we can stop with the lecture part of this if that's okay. Brilliant.